I'm Dr. Andres Fonseca. I'm a consultant psychiatrist and I'm an honorary lecturer at UCL, and I'm the CEO at Thrive. And we're doing a seminar today on the menopause. With me, there's Johanna. Johanna, do you want to say hello and introduce yourself as well?
Yeah, good morning, everyone. It's so nice seeing so many of you here today. So welcome to the session, yes. And I will keep an eye on the chat function and Q&A function. So if you have any questions, please feel free to put them in there and I will interrupt Andres, or we will come to them later today. So yeah, feel free to ask anything.
Yeah, so there's a Q&A function, you can use it, and so then everybody can see your question when you use the Q&A. You can also use the chat. I think Johanna will be keeping an eye on that. Yes. And she will interrupt me, so if there's something that I'm talking about and that there's a question that is relevant, she'll interrupt me, and also we'll have some time at the end to go through any questions. So yeah, I mean, I'm very happy to see so many of you. This is a very important topic. It's very important to me from a clinical point of view. I'm an adult psychiatrist and I'm also an old age psychiatrist. So they're two separate specialties for us. And I did both, and my area of interest has always been the transition between one to the other. And of course, in my clinical experience, I've had a lot of women that were going through the menopause, and that's what increased my interest and helped me sort of learn a lot more about this, and actually is the thing that made me quite passionate about this topic and about how much misunderstanding there might be about it, even within my own colleagues. So I've made it a little bit my mission to sort of try and correct some myths and talk about this as much as I can. Of course, I focus in my area of expertise is mental health. So my particular emphasis has always been on the interaction between the menopause and mental health. So I'm going to go through a whole overview of the topic, but I will make particular emphasis on the possible links between menopause and mental health conditions such as depression and anxiety. And I also discuss the management of the symptoms. It is the symptoms, so the worse the symptoms are, the more likely you are to experience the mental health conditions that I talk about. So basically those symptoms of the menopause are the thing that tends to drive most of the problems associated with it. I'll talk about the use of hormones, of course, but I also talk about the use of other medication and where it might be indicated, so that you get an idea, or that, if your GP mentions some of these things, you at least have a feeling for it or have heard of it. And I discuss interventions that don't use medication at all. So I mean, let me start by just defining the menopause. It seems obvious, but I think it's good to have like a good understanding of what it actually is. Is the phenomenon whereby a woman who has had menstrual periods stops having them for at least 12 months. That's kind of the strict definition. And this is also part of the definition is that it has to be, this stopping of the periods, of the menstrual periods, has to be as a result of the changes in a range of reproductive hormones. And the key hormones in this process are a few that you probably never heard of. So anti-Mullerian hormone, follicle-stimulating hormone, and inhibin B. So all of these that you probably haven't heard of are the ones that actually regulate those periods. And of course, the biggest one, the one that is actually, that we know for a fact is the one that is associated with the symptoms, is the drop in estradiol level. So these hormonal levels, the other hormones, change over the course of years, usually before the last menstrual period, and there's this perimenopausal time which may last for years before the last period, and where these all these other hormones are dropping down, or they have unstable levels, let me put it that way. So therefore periods may become more irregular during that time, and then eventually what happens is there's like an acute drop in the estradiol levels, in the estrogen levels. So during those transitions, the transition phase, even before periods stop, you may have some of the characteristic symptoms arising. And also, of course, the transition may in itself take a long time. In other cases, it might be very regular and then all of a sudden completely stop quite abruptly. And there's the hormonal changes, even the estrogen changes may be in some women quite abrupt. In most women is fairly abrupt if you compare to other changes, but in some women it's particularly abrupt, which again, the more abrupt, the correlation seems to be the more abrupt that drop in levels is, the greater the chance of having the symptoms, or having particularly strong symptoms.
There are actually two questions already.
Yeah, okay. Let's
One
go.
is, how do you know if your period has stopped if you're still taking decongestrol pill and don't have any periods anyway?
Yeah, well, that's a very good question. So you may not know for that reason. That's why, it's very much as a result. That's why it says the stopping of the periods has to be as a result of a change in the endogenous hormonal levels. So you may not know. So because you do have those things in change, you may not know. And there might be other reasons why periods have stopped, not just the hormonal changes. So the menopause is the ceasing of the periods because of this change in these hormones that your body will generate naturally. So you don't know. So that, if your periods stop for other reasons, because you're taking a supplement, because you're on progesterone, because any of those reasons, then that's not the menopause, if that makes sense. So it has to be this drop in the estradiol levels that your own body secretes. Sometimes I get a question that is related. Can we do a blood test for the menopause? And the answer is no. It's well, it is possible, and sometimes you do it clinically to do hormone levels. Most of the time it's like zero value to do it. It's kind of like puberty. So it's a process, it takes a while, and then, the first period, and, these are changes that happen over time. But you don't do a blood test to detect whether, you started having periods and whether your menarche has happened. Same thing for the menopause, is not all that useful. I think one of the things that one might want to sort of think about is, am I getting any of the symptoms that is correlated with the menopause? And if I am, that probably means that the estrogen levels, that my own endogenous, the one that I produce myself, my own bodily estrogens might be dropping in level. So that might be worth consulting. So if you're on medication or you don't have periods for other reasons, for example, you may not have, you may have had a hysterectomy and you still have your ovaries, right? In that case, your periods will have ceased, but it's because you've had a hysterectomy. So the thing to look at would be the symptoms. That's what would prompt the consultation, if that makes sense. So one last remark that I wanted to sort of make about this is the last line there, that it happens between 45 and 55. The average age in the UK is 51. If it's early, if you get the symptoms, particularly if they're very serious, it's always worth a consultation. I'm going to be repeating this a lot. Even if you haven't had a lot of symptoms when your periods first stopped and you get them later, that's worth a consultation. It's not that you went once and that's good for all time. It's worth sort of going back and asking about it. If your symptoms change, that's important. And definitely, if it happens before the age of 45, definitely is something that needs to be examined and explored. Are there any other questions, Johanna?
Yes, actually many already.
Okay.
Yeah, so the next one would be, how long can the pre-menopause period last?
Yeah, so it can actually last for years sometimes, so it can be it varies tremendously from person to person, from woman to woman. So it can be years. It can be, and actually the period after the last period, the menopausal symptoms after the last period, those can also last for quite some time. So yeah, so there's both of those things. Let me talk a little bit about the symptoms that might take care of some of those questions.
Yeah.
So most women will experience, I'll come back to you in a minute, Johanna, but I think some of this will answer some of those questions that maybe we're getting now. So most women will experience some symptoms during the menopause. It's about So it's about 25% will experience quite severe symptoms. 25% kind of don't experience much in the way of symptoms at all. And then there's 50% in the middle. So about 75% of women, that's what it means, will have some symptoms, and a quarter of all women will have severe symptoms. So a third of those that have symptoms have severe symptoms, quite disruptive symptoms. So the symptoms can be very disruptive. So this is very important to understand, and they should not be ignored. Is my thing that I keep banging on about. So even though it is part of normal aging, I don't think it's reasonable to say to yourself that you need to put up with the symptoms, because they can be, as we say, very, very disruptive. It's important to avoid over-medicalizing the menopause. I understand that I agree with that. It's a process associated with normal aging, but on the other hand, it's very important not to under-medicalize it. And in the average cases, worth consider consulting with your GP and discuss whether hormone replacement therapy is right for you. That's the one important thing to understand, is that the symptoms can be so strong that it may feel at times like a medical emergency. The symptoms of the menopause in themselves are not dangerous, but of course, the menopause changes the risks of some things. For example, interestingly, the risk of cardiovascular disease goes up. So women seem to be well protected from heart disease because of the presence of estrogens as compared to men, for example. And when estrogens start disappearing, the risks, those cardiovascular risk factors start catching up to those of men, because obviously women will have testosterone in their system, and the testosterone signal becomes stronger in the absence of estrogens, which is another interesting phenomenon. So yeah, I mean, answering the previous question, it can last for years before the last period, because the perimenopausal period, whether those periods are irregular, can be quite long, quite prolonged, and also it can last for years after the last period. So yeah, so it can go both ways. In most cases, it tends to be at least quite a number of months. Even in those, so there's, as I said, 25% of women that don't experience any symptoms. Even in those 50% of women that experience some symptoms, it can last for months, and in some cases, it can last for years. Okay, so what are the actual symptoms? I've got them here. So we've got the vasomotor symptoms that are the ones that I'm going to sort of focus on before. So I mean, here's a list of all the symptoms that I'm going to sort of talk about, but I want to sort of talk about the vasomotor symptoms first, because they are the most frequent. Before I do that, Johanna, were there any other questions that?
Yes, there
are.
So are any of those 4 hormones, another name for the estrogen?
No. So estrogen is only the estradiol is the estrogen.
Okay.
The others are hormones that your body uses to regulate periods in various ways, to regulate the monthly cycle. Mm-hmm. But the estrogen is secreted by, those are produced by the ovaries, and they're a thing unto themselves. The others actually are produced in your brain, for example, a lot of them, which is interesting in itself. Yeah, so only the estrogens, so the estradiol is the estrogen. The rest are not.
Okay, great, thanks. Then another question, could you explain the follicle stimulation mentioned on the previous slide?
Yeah, so the follicle stimulating hormone, and the LH, the luteinizing hormone, these are 2 hormones secreted in your hypophysis up in your brain, and they actually regulate the monthly cycle. So they stimulate the follicle. The follicle stimulating hormone stimulates the follicle so that you get the ovulation going, basically. So when you have an egg, it kind of, one or 2 of them, sometimes more, are kind of quote unquote selected, and that follicle that contains the egg is stimulated, it grows over the cycle, and then it ends up bursting, and that's where the egg comes out and goes into the fallopian tube, and that's when when your ovulation occurs, So the follicle stimulating hormone is the hormone that starts stimulating the ovary to produce that egg, to select one and produce that egg. Yeah.
How long does the actual menopause last? I think you answered that, right?
Yeah,
depends.
I think so.
Yeah.
Well,
right.
it very much changes from woman to woman. Yeah. What we're calling the symptoms of the menopause. The menopause itself is just that you haven't had any period for 12 months. That is kind of the strict definition, as a result of those hormonal changes. Yeah.
We come later to the supplements you can take. So
medication-wise,
so
I'll address all that in a minute. Yeah.
And then is flooding a part of the perimenopausal stage?
Flooding?
Flooding, sorry.
Sorry, I don't know what that means.
F-L-O-O-D-E-N-G. I don't know.
Okay, let me see. It might be a synonym for one of the symptoms that I'm going to sort of be talking about in a minute, I think. So I don't think I've heard that term specifically. But let me see if we address it. If not, whoever asked the question, please ask it again so we can clarify exactly what is meant by that term. So we have the vasomotor symptoms, and these are the hot flushes, the night sweats, and the reason we think this happen. So I list them together because they are related, and they are very much linked to the level of estrogens in particular, and they're caused by this decreasing level. And the bigger the decrease, the more significant they are. So the bigger the drop, the more significant they are. Interestingly, the estrogens have an effect on the temperature regulating system in our brains. Well, in women's brains. So that, over the cycle, that's why it's used sometimes to predict ovulation, your temperature, because it changes through the cycle. So the estrogens seem to have a temperature regulating function. So when estrogens are not there, this mechanism of regulating the temperature starts to malfunction. It expects to have this estrogens, is not seeing them, and it becomes overly sensitive as a result. It becomes excessively sensitive. And that's why almost anything can trigger the response where the body's trying to get rid of excess heat. That's the hot flushes and the night sweat. So those two mechanisms are obviously sweating, and also opening up all the little blood vessels in our face, in our hands, in our legs. So they open up to try and shed all that heat, and that's where you get all the burning sensation, all that flooding of heat that you feel like a furnace. So some women describe it as being in a tanning bed. I've heard it described, or feeling like you are a hot furnace of some sort, and it spreads all across the body. And this sensation can last several minutes. It can be quite intense, as I was saying before. So women who experience night sweats describe also waking in the middle of a night covered in sweat, even though the bedroom might be cool. It might be even in the middle of winter. And they're wearing sort of appropriate night clothes, but they still happens. And the amount of sweat is enough to soak through the night clothes and even the bedding. So there is. I've got a paper there. Some of you might be interested to read about these vasomotor symptoms in detail. It is a scientific paper, but is well written. I think it's accessible. That's why I selected it, and it kind of goes into the mechanisms for these symptoms, what we know about them. So that might be interesting to some women, for some women to read, and for some men as well. Poor sleep is a big one. And it's actually associated with many of the poor consequences of the menopause, is this poor sleep. So the other two symptoms may have an impact on sleep, but also we think that it might be also independent. So there might be some kind of a sleep regulatory effect that estrogens play that is not well understood. So it may be that there's a link there as well. So it's clearly correlated with the vasomotor symptoms, with the hot flushes and the night sweats, but there might be more to the story than that. And all aspects of sleep can be affected, including getting to sleep, waking up many times in the night, or waking up too early and being unable to go back to sleep. There's this paper that is very recent, looking at this insomnia and depressive symptoms during the menopause, which actually talks about why this might be happening and why it is probably then the vasomotor symptoms, but there might be more to it than that to the story. That's why I put it up there. So we also have the ones that, these are the ones that perhaps I was most interested in initially, but of course there's a link, there's a very deep link between these and the other symptoms that I've been talking about. The vasomotor symptoms are the ones that are linked to having low mood and having anxiety, and also, of course, they're linked with poor sleep, and also poor sleep is linked with depression, with the risk of depression and anxiety. So it becomes a bit of a vicious circle. And of course, if your depression or your anxiety is poorly controlled, we also know for a fact that you're more at risk of having more of these vasomotor symptoms happening, and they're more intense and more difficult to cope with. So there's a bit of a vicious circle going on there, which is kind of important to understand. So low mood and anxiety, relatively common in the menopause. In some cases, low mood or anxiety seem to be present even before other symptoms. So you cannot say that it's purely due to the vasomotor symptoms or to other symptoms. So in other cases, it happens at the same time as the other symptoms. These mood symptoms present at the same time, when they are heavily correlated with the vasomotor symptoms, that might be the best target for action, but they might not, as I said. So you might need to think widely about that. And the sleep disruption is an important factor there. So the answer there is that these are all probably correlated. It's complex, and that's where I think it's an important function of the consultation that you have. You're just not necessarily just interested in the vasomotor symptoms when you're having a consultation with a woman about the menopause. You're also interested in these other things. And I believe it's very important to screen for the presence of depression and anxiety in the menopause. So anxiety, the risk is 60% greater during the menopause. So it's 1.6 times. And depression is much, much greater, 2 to 4 times greater. So it's 200% to 400% greater. So it's quite an important thing. So depression in particular is the one to watch out for. So concentration and memory problems, a lot of women complain about this. These are also things that I tended to see in my clinic, because the GP might say, oh, I don't know about this. And then I might get the question, because I also have an interest in memory. Again, that transition area that I was talking about. So they report problems with the memory and concentration during the menopause. Seems to be, what is purely associated with the menopause seems to be temporary, and is characterized by a difficulty in learning new things, specifically the one that is linked with this. So when people ask me, how do you tell it apart from A, normal aging, or B, something else, some other condition affecting memory? Because in the menopause, it seems to be temporary. It seems to be correlated with sleep. It seems to be correlated with vasomotor symptoms, and also seems to be about learning new things specifically, rather than other cognitive functions. And it seems to be something that disappears once the symptoms are well controlled. And it might be linked to sleep, might be linked to mood problems, as that we've already discussed, might be linked to the hormonal changes, although I don't think that is the case, because when we correct the mood problems and the sleep problems and the vasomotor symptoms, the memory problems seem to get corrected as well. So we know that there's a complex interaction there, but yeah. So this is another symptom. Some women worry quite a lot about this. I'm sure we'll get questions about this. Are there any questions, Joanna, that I should be?
Yes, so there was an explanation of the term we struggled with before. So it means heavy period for the first 2 to 3 days, and just the sudden surge of heavy bleeding.
Yes, sorry, yes. So it might be because the hormonal regulation of the whole thing is not as precise and perfect as it used to be, and it may result in irregular periods, heavy periods, or the opposite. Now, it may not be. That's the other important thing. So if it's something that you've detected recently, I would not necessarily just assume that is part of the menopause, I would probably, if it's causing a problem, if it's something that is sustained, and if it's really sort of debilitating in some way, I would seek a specific consultation on that, just in case it's something else. It could be, but it could be other things. So it might be important to consult, if that makes sense. Yeah.
Yeah.
Oops, sorry. Where was I? Poor sleep, low mood. Yeah, so concentration and memory. The next one, or was there any other?
Yeah. Yes,
sorry.
there are many. I think so. Just let you know, we will answer any outstanding questions in the end, but I will try to put some during Andres' workshop. So there's one. Is there anything I can do about the heart palpitation and
The palpitations,
as they do scare me at times?
yeah, so they can be very, very pronounced, and they come with the hot flashes. Usually they're linked to the hot flashes. So actually, I mean, I'm going to talk a lot about that and about how to manage that, because some of the things that we're going to do, particularly in the non-pharmacological interventions, the more well-being interventions, psychological interventions that we can have for the menopause, a lot of them are also helpful specifically with these other symptoms, such as the palpitations as well. So I'm going to sort of make an emphasis on that a bit later. Yeah.
Yeah.
So go ahead, Johanna.
Yeah. Then there was another one. Can the symptoms vary throughout going through the menopause?
Absolutely, is what I was saying before. So you may have in the perimenopausal period, you may have changes in these hormones that we were talking about. Those may result in a change in the level of estrogens over time. They may drop abruptly, and they usually do, but they may change in levels just before they drop, and the symptoms may change over time. So, and also after it ceases, after you had your last period, that also may have differences in the symptoms themselves. That's what I was saying before. You may have had a consultation, maybe at the beginning, with your doctor about this. Maybe the symptoms were mild at that time, and you decided that it was not worth doing very much about it. You know, thinking about it with your doctor, you said, okay, let's just watch and see. And then they get worse. And then some women say, well, I've already had a discussion with my doctor, I'm not going to go back. No, I think if you see a change for the worse, obviously, then it's worth a consultation again. And it may happen, definitely. Yeah, they can change through the whole perimenopausal period, the period before and the period after that last menstruation.
Yeah. Great. There was a question about how soon should you seek medical help?
When the symptoms are troublesome, and my threshold would be low. Mm-hmm. That's what I would say, because what you don't want is to get into the place where you're not sleeping well. You don't want to be putting yourself at risk of having depression or anxiety, for example, and you don't want to be really enduring those horrible, hot flashes and all of the other symptoms that are associated with them, including the palpitations, like we were saying before, and some of the other symptoms that we're talking about now. Yeah, definitely. So vaginal dryness and discomfort during intimacy is an important symptom. It's something, again, that I heard about in my clinic quite a lot. So this one is the one that is perhaps best understood as actually there's like a 100% direct link between estrogen levels and these vaginal secretions. So because these vaginal secretions and the estrogen levels help maintain an appropriate environment that protects against infection. So it's actually very clearly understood, that link. Okay. So the thing to say when I talk about the management, is important to know about how to manage the dryness specifically, and not to do the wrong thing here, because that results in some it can result in some bad consequences. I'll talk about that later. So headaches, including migraine, of new onset migraine. You know, I call it migraine because I was taught by a neurologist who always called it migraine, and I adopted it. But migraine, new onset migraine can happen during the menopause, and also might be difficult to treat. Sometimes, interestingly, it might be linked to low. You know, when you're having HRT, the HRT might be too low, or also it might be too high, and both of those have been linked with having an increased risk of having migraines. the palpitations and the heartbeats are commonly reported. And these symptoms, as I said, can be months. All of these, they can present at different times, they can vary over time, and they can last around, I mean, actually, we have cases reported of 3 and 4 years, as like I was saying before, after the last period. And in some cases, it might even last a bit longer than that. Yes. So how do we manage these symptoms? I'm going to go all the options. Before I go any further, if you experience any symptoms, you should not assume that you have to endure them. I keep repeating myself, but it's important. This can be extremely distressing. I think people should, I don't think that people are not going to take them seriously. Hopefully, if they're not, don't take it seriously, it's their fault. Let me put it this way. So if you're worried about your GP not taking you seriously, you need to consult with a different GP. Now, in every surgery, there usually is one GP that has a special interest. Yeah. And it's about having a consultation, maybe with the nurses, maybe with the receptionist, somebody who's got a special interest in the menopause, and just talk to them. And also, I mean, sometimes there's a nurse, and they can be very good, that has an interest, but it's always what, and some nurses are nurse prescribers that have a special interest here, and they can be very good, and they can be very good advocates as well. So some of those nurse prescribers that have an expertise in the menopause, it might be worth asking if your surgery has one. So don't put up with it. Do seek help. Don't feel like you're going to be dismissed. If you're being dismissed, you do have a problem. You should not be dismissed. They are doing the wrong thing, if you know what I mean. So it's their fault, not yours. But they're not doing the right thing. So take it seriously. Even the sleep, just the sleep problems by themselves can cause a host of other health problems. So please do it. Okay. So the number one treatment is obviously hormonal treatment. This has garnered a bad press over, and people tend to shy away from it. I wouldn't shy away from it. So there are cases in which obviously there is a contraindication. There might be, perhaps sometimes it's due to a family history, a particularly strong family history. There might be other reasons why it's contraindicated, but I think it's always warranted to have a careful thought about this and whether this is an option. It tends to very many times get dismissed too early. That's what I would say. So this can be an estrogen plus progesterone, and depending on in the individual case, and it can be given as tablets, it can be given as a gel, it can be given as a patch, it can be given as an implant. So there's options there. You don't necessarily need to take tablets. There are other options available. Now, this is an area of specialist prescribing. I don't tend to prescribe these. I do know about them, so I will answer some questions about them, but I prescribe some of the other drugs that we're going to talk about later when I'm prescribing, not these. But yeah, and also, I mean, it's important to say, maybe, and I've heard this said to women, these are not the same as the pill. These are specifically formulated, they're much stronger, they contain a lot of the estrogens that your body is no longer producing, whereas the pill is formulated for a time when your body is still producing its own estrogen. So that's the important thing. So for vaginal dryness, is what I was saying before, estrogen creams are the best option. There may be, again, it needs to be specifically formulated for vaginal use when you have the dryness. Don't just use any soap, any perfume soap or washes or douches. Those can lead to problems. Those can lead to infection. It has to be specifically formulated for vaginal use. If you're in doubt, ask the pharmacist, ask your GP about which one specifically to use. And the reason I mention it again is because I've been consulted, and I've been sometimes having a discussion about this with women myself. So non-hormonal treatments for vasomotor symptoms. The number one, interestingly, is one drug that I usually do prescribe. So there's a kind of antidepressant called selective serotonin reuptake inhibitors, SSRIs, that have shown to be effective in reducing vasomotor symptoms in the absence of both anxiety and depression. So in this case, interestingly, they're prescribed purely for the vasomotor symptoms. So don't feel like when you go to the GP, and the GP might suggest some of these because it's in a specialist area prescribing for them, that they're thinking that you're depressed or anxious. They are directly solving a problem. So the medication work by increasing the level of a neurotransmitter in the brain called serotonin. That's why they're called serotonin selective reuptake inhibitors. So it increases the level of this neurotransmitter called serotonin. Neurotransmitter is a chemical that the brain cell use to communicate with one another. So these medications have names like paroxetine, fluoxetine, sertraline. Sertraline tends to be the one most commonly prescribed. Seroxat is the commercial name. So they seem to be directly counteracting, this is the important bit, they counteract the reduction in serotonin levels that follows the decline of estrogen in the menopause. So for not perfectly understood reasons, the estrogen levels drop, and as a result of that, the effect that they have on the brain is that the neurons that make this, the brain cell that makes this serotonin stop producing it as they normally would. And that seems to be linked to various effects that the serotonin may have, including this temperature regulation that we were talking about. But this also is probably the link, the direct link that I was talking about. Nothing to do with the vasomotor symptoms directly, nothing to do with the sleep directly, but a direct effect of the estrogens on the serotonin levels and increasing your risk for depression. So this seems to be the mechanism. So an alternative to these antidepressants are drugs called gabapentin and pregabalin. These are medicines that initially were created to treat epilepsy, and though they have their effects, on the calcium levels, calcium channels in brain cells. So they change the calcium, the responsivity of the brain. The brain cells use this calcium signal to basically do their job. Let me put it this way. And what happens with these drugs is that they regulate the firing of the neurons, the firing of these brain cells, by regulating the function of these calcium channels. And when you do this misfiring that you get when all the thermostat that you've got in your brain misfires, and then you get the hot flush, you get the sweats and everything else, stops misfiring so readily, and therefore it's less likely for it to happen, and therefore it takes care of those symptoms. So it does it that way, through regulating this the susceptibility of these brain cells to misfire. That's kind of the thing. Clonidine is a medication that is given for high blood pressure, and it can stop the hot flushes directly. Now, the problem with it is that, again, it needs to be carefully prescribed because it can have bad side effects. So in some cases, it might be worthwhile, but it does need, that needs special knowledge. So it needs to be maybe a GP or even a gynecologist who has a lot of experience in this area. Oxybutynin is a tablet that is given for urinary incontinence normally. It blocks another neurotransmitter called acetylcholine. And there's 2 good studies showing that oxybutynin can be effective in the symptoms, in the vasomotor symptoms, in both healthy women and also breast cancer survivors. Again, breast cancer survivors, that's an area where hormones might not be possible to use. So there we go. We have non-pharmacological treatments. Johanna, do you want to stop me?
Yeah, no, there was just a question if you could also take those supplements or to relieve the premenopause symptoms.
I'm going to talk about supplements in a minute and about what we know about them in detail. Is that okay? So yeah. I think I'll go to the supplements after I go. So the number one non-pharmacological is exercise. I'm sorry to say, some women sort of say, okay, so again, you're going to tell me about exercise. You too. Well, the evidence shows that it's actually very effective. And actually, the reason we know it's actually very effective is because, listen to this, nobody makes any money out of exercise. And if it keeps coming up as an effective treatment, there is something to it. Because there's no incentives to say that exercise is better for you. Okay, so nobody's making any money out of it. There's no pharmaceutical companies that are going to sell it to you. So, there probably is something to it. So it's probably worth paying attention to this. So weight loss can be effective in some women, as there's a higher risk, there's a clear higher risk of having vasomotor symptoms in women with a high body mass index. There are other benefits, such as probable improvement of sleep already. The joint pain tends to improve also with exercise, and the stiffness that you get sometimes in the menopause, that tends to sort of improve with exercise. So we have a study here, again, to try to convince you that it's worth your time sort of considering it. There was a study by Bailey and colleagues that shows that it reduces the severity of hot flushes directly, and it's got demonstrable benefits on the pain, also depression, of course, and sleep. So there we go. There's the reference there if you're interested at all in taking a look at it. We'll make this available, by the way. We'll make all of this available later. You can download the program and watch it again. And if you have any sort of a specific bits of it that you want to sort of hear again, then you can look at it. This is where I was going to talk about supplements and herbal remedies. So let me do that, and then we'll go back to some other questions. So there is an in-depth review. Actually, I don't have the paper reference on this one, but I can give it to you. Where when it was published in 2013, very, very comprehensive review of all the kind of herbal remedies, supplements. What is the evidence around all of this? So we know that these chemicals present in plants called isoflavones can be effective, and also this thing called purified pollen extract can be effective. They may show some benefits. Now, there's a problem. Isoflavones, if you look at them, if you look at the molecule, they look very similar to estrogens, and that's how we think they have their effect. That's why we think they may be effective. The problem with them is that obviously if HRT is not recommended, isoflavones will probably not be recommended either, because they probably do the same thing. And also, if you are taking HRT, it's probably not a good idea to also have any of these remedies that contains isoflavones, because you may be overdosing as a result of it. You may be taking too much as a result of it. So there's also some evidence for black cohosh. The ones that I'm not mentioning is because there's no evidence behind them, like zero. But black cohosh, yes. The problem with it is that it also has important side effects if the dose is incorrect, if it's not done carefully. So the important thing to remember about all of these is that currently there isn't enough evidence to recommend them. This is because the studies tend to be poor quality in general, and the research is patchy. The main reason, the main problem here is that they're not regulated. So these herbal remedies for the menopause that you might find in the shop, I don't know what's in them. We don't know what's in them, and because they don't go through the normal approval process that a medicine goes to, I as the manufacturer can put whatever I want in them, without proving whether they work or it doesn't, or at what dose or anything. So that's the main thing. So they may interfere with other medication that you may be taking, like clearly in the case of isoflavones, but also other remedies may interfere. And because we don't know exactly what is in them, and nobody's demanding the manufacturers to tell us exactly what is in them, then it's a bit of a Wild West. Now, there are some prescribers, some specialists that do know about these products and these manufacturers in detail. If somebody's looking after you that has good knowledge of these, then under their supervision, that might be a good idea. Under their supervision, that might be a good idea. So I know that there's some nurse specialists in this area that actually do use them and do understand the manufacturers, do know exactly that's why they tell you this brand and not that brand, because they know exactly what each manufacturer puts in those remedies. And under those circumstances, it's safe. But, for example, we have reports of black cohosh causing liver damage because it was the wrong formulation and the wrong dose. So it can be as serious as that. I will say something quick about acupuncture. You've got it there. It's not shown to be any different than placebo. And acupuncture, must remember, they are piercing your skin. So there's always an increased risk of infection as a result of it. So in general, it's a bad idea unless there's good evidence, and in this case, there's no evidence to recommend it. So yeah, so just for you to know. Psychological interventions. So this is a comprehensive review that was published in 2017. Very good review, I would say, and goes through everything. And it's purely looking, I mean, mainly looking at the vasomotor symptoms, but they're very good in seeing what works and what doesn't work. So they found that yoga, for example, did not offer any specific benefits over any other form of exercise. However, exercise is very good, must remember. And if you find yoga particularly helpful and you like that form of exercise, then it has a lot to be said for it. It's just that there's no specific form of exercise that seems to be superior to any other form of exercise, if that makes sense. But yoga is a good form of exercise. Reflexology does not appear to, reflexology is these massages that they give in your feet with very unclear logic about how they work, some kind of about reflexes in your feet. There's no reflexes in your feet in the way they describe them. Doesn't matter. The thing about it is that it can be quite relaxing. Now, it's not any different, the benefits that you get from it are not any different from any other good massage that you might get in any other way. So there are benefits to it. There are benefits to massage. They can be relaxing and quite a good experience, and it can help with the vasomotor symptoms. But so no form of massage is superior to any others. Is the other thing, and the effects are, largely placebo effects, but not to be dismissed. Placebo effects can be important. The problem with placebo effects is that they tend to work at the beginning and then wash away. So you may respond to them during a month, and next month you're still doing it, but it's not having the same effect. It's not, the effects tend not to be sustained with placebos. That's not to say that having a nice massage is a bad idea. I think it's a good idea. Okay, what about the ones that specifically do work? So applied relaxation is a particular form of relaxation training. It's in the app, it's in the Thrive app, the full program there. And it's been shown to be beneficial. It reduces both the frequency and severity of vasomotor episodes. This is one of the things that I was always recommending in my clinic. It's a training, you learn it, and then you can just do it yourself. So the effect and severity was sustained at follow-up, which suggests that retraining might be helpful. And that's the good news about having the app, because if you need a refresher, it's always there for you. So to just do a little bit of retraining if you need it. And it may be very useful in keeping the severity and the frequency of the symptoms under control. So mindfulness-based stress reduction was effective to control the severity of episodes, but unfortunately not the frequency. It's still commendable or something to be recommended, because you can actually use it during. You can use one of these techniques during an episode, and that may make it, that seems to make it less intense. So the effects were not maintained 3 months follow-up. However, because for example, we have it in the app, you can do retraining so that you can maintain those effects over time. So again, regular practice and retraining may be useful, maybe a thing to do. This is included in the app, all the mindfulness-based exercises. An unguided meditation focusing on the palpitation and all those other things, even when they're unpleasant, might be quite helpful. There's something to. I would try with a concentration with the other forms of meditation first until you get a good ability with them, and then probably do an unguided one, looking at the symptoms themselves, or focus on the breath while you're having the hot flush. Might be useful to reduce the intensity of the hot flush when it's happening. Hypnosis, visualization, and related techniques seem to also have a beneficial effect during training and after follow-up. And we have a technique again in the app. It's called self-suggestion, and it basically teaches you this technique. And what you do is you use the cue that you have during one of the episodes to reduce its severity, and you may also be able to stop it from even happening at times. This is an advantage. The last three also have the advantage that they're helpful in anxiety, and they can be very helpful with sleep problems. So, these techniques have multiple applications here. Finally, CBT has shown to have a good ability to reduce the symptoms during the training, at 12 weeks after the training, and at 6 months after the training. It is the one that's shown the best benefits all around and the most long-lasting benefits. One other advantage of this technique is that it can be applied to depression, of course, and it can be applied directly to sleep problems, of course. And within the Thrive App, we have a comprehensive CBT training program, not specific at this point. We don't have a specific module for the menopause. I will introduce it later. This is one of the things that I have in the pipeline. But the basic techniques are all there that can be applied. It's about the situation. If you look at the situation, if you ever do it, if you look at the situation component, the situation is you're having a hot flash or you're having a vasomotor attack of some sort, and you work from there. So there we are. My quick things to take away: the menopause may present in very many forms. It can change throughout its life, its course, and different women experience different symptoms. 25% of women no symptoms, 50% of women mild to moderate symptoms, 25% of women quite severe symptoms. Recommended the threshold for consultation with your GP very, very low. I've spoken about the hormonal replacement and why that is the best. That is the first and best choice. If it's contraindicated, there's other medications that can be used, including SSRIs for various reasons, which is probably the number one treatment. And we have effective non-hormonal treatments. Remember the importance of weight loss and exercise. The cautions I told you about herbal remedies, some of them are worthwhile, some of them might be worth pursuing, but it needs to be with a specialist that actually knows and understands them and knows the manufacturers. And the relaxation techniques are effective. There's three in particular: mindfulness-based, applied relaxation, and other forms of relaxation are in themselves effective, and CBT is effective. Those are the things to take away. I've got a book here that I recommend. It's called Estrogen Matters. For those of you that might be a little bit reluctant to take a hormone replacement therapy, even though the doctor might not have spoken to you about any contraindications, you might yourself be reluctant because of this quote-unquote bad press that it has acquired. So it goes through the evidence, through the pros and cons in a very clear way. It's written by an oncologist and a psychologist, and it answers. It's for a lay audience. It's very well written. I personally found it very useful for myself, and it helped me explain things better during a consultation with a woman going through the menopause. So there we are. So thank you very much, and I wonder whether there's any. I'm sure there's questions.
Yeah, there are many.
Johanna?
Okay, so I will start with one who would really like to ask the question. She raised it a few times. Can you become anemic whilst going through the menopause?
Can you become anemic whilst going through the menopause? You could, not necessarily as a direct result, but yes, it is possible. You could be having excessive periods, particularly during the menopausal time, this flooding that we were talking about before. So you can have very heavy irregular periods. You may also have other conditions that may make it more likely for you to be losing more blood than usual, and that may be conducive of you becoming anemic. You may have other, for example, if your symptoms are causing you for whatever reason, putting you off your sleep, so they might compound the problems, and yes, it may result in something like this. However, what I would do is, if you suspect that you might be anemic, that might not be the reason, there might be other reasons, and it's important to investigate it fully. So it's important so when I say there's no use for blood tests during the menopause, is use for hormone level blood tests. But because it has health implications such as this, it is important to get, I usually did it in my clinic even if I didn't get it from the GP when I get a referral, I usually did a blood test looking at everything else that might be going on at the same time that I need to take care of. And it might be that you discover this, and it might be that it requires separate treatment above and beyond what you're doing for the symptoms of the menopause, if that makes sense.
Great, yeah. If you already experience anxiety and have had episodes of depression in the past, are you more likely to experience anxiety and depression during pre-menopause or menopause?
Yes, it very much appears to be the case. Yeah, so you are at a higher risk, and it's worth sort of consulting with your GP about this, and maybe having a referral to a specialist because you're at a higher risk. I would say definitely worth discussing with your GP and whether it's a good idea, if you're experiencing the symptoms of the menopause, to get a consultation with a specialist, somebody like me, for example. That might be a good idea, yes.
Mm-hmm. Is weight gain another symptom of changes in hormone?
Yes, and actually what happens is that the fat distribution can change. So from a more female typical fat distribution in your body, it can then change to more around the belly, for example. You may gain weight and it might all go to your belly. And that is because the estrogens are dropping off and you do have testosterone on board. So you tend to start to have a fat distribution that looks more like a male fat distribution rather than a female fat distribution. And again, that particular fat distribution around the belly carries its own risks. So yes, it may cause this, and it may cause these changes in the fat distribution specifically. And that may be worth of attention, yes.
One more. What if your periods have stopped but you are anemic?
Again, so it's worth investigating the cause of the anemia. So, obviously that's not explaining it. There might be other things going on. What is it a poor absorption? So that would be beyond the menopause, I would say. I would look at it as this is new onset anemia with no clear cause. What is causing it? Let's investigate. Is it a dietary insufficiency? Is it something else? Is it a poor absorption problem? Is it, there might be a number of reasons that are causing it. And it's the specific type of anemia that might reveal it. It's not just anemia. It's about what is the distribution. Are the volumes, for example, the red cell volumes, are they big or small? Are there immature red blood cells that we see in the blood test? So it'll be worth investigating in its own right. Not necessarily thinking that it's linked to the menopause. It's just investigating it widely would be important.
Mm-hmm. There was one about emotions. What triggers the mood, angry and emotional episodes? Is this part of the menopause symptoms, and how can we how to relieve these?
Yeah, so we know that estrogens do have an effect on the brain, and we know that they do have a regulatory effect there. When estrogens drop very abruptly, as I said before, we know that there's a knock-on effect on the brain cells that use serotonin to regulate mood. Okay, so we know that happens during that period, and that's why, interestingly, the SSRIs specifically seem to help with both the vasomotor symptoms, okay, and also the mood symptoms. So there seems to be, so how do the mood symptoms and the mood fluctuations work? I think it's a complex picture. I think it is probably a direct effect of the hormonal change, the lack of estrogens. That is a part of it. If you are having vasomotor symptoms, they themselves carry a meaning for you and have an impact and make you feel, because they can impact your function. And then you might be thinking about, okay, so you might be thinking about, what does this mean for me as a person? Am I changing? is my identity. They can even threaten your identity, these changes. So those kind of things, those kind of that transition that you have to go through can in itself be quite impactful and can affect your mood. So from a psychological standpoint, there might be an effect there, if that makes sense. The symptoms themselves can be quite distressing. That adds to your stress. So therefore, there is just the bad experience that the symptoms give you, maybe a component of those mood changes, if that makes sense. And thirdly, sleep. Sleep, we know, if sleep is not well, if you're not sleeping well, your risk of depression, your risk of anxiety, your risk of having this mood, untoward mood fluctuations is much greater. So, and this is affect, forget the estrogens, just link to the sleep itself. So by, if for example, if you're able to, in a woman who's having difficulty sleeping, even if you don't do very much about the hormonal changes, if you manage, because you can't, imagine that they cannot tolerate HRT for whatever reason. If you address the sleep problem through other methods, the mood problem tends to get better. So that is a very clear link between those two. I hope that answers the question. Is a nuance answer, because it's got it's a multifaceted issue in this case. Yeah, I hope that, I don't know, Johanna, do you think that was clear?
Yeah, I think it was good. Yeah. If not, please feel free to let us know.
Yeah, feel free to let me know.
Yeah, there are very still many questions left. I don't know how long time we have. I think
should we do two more? Let's do two more.
Yeah.
Let's get two more because it's great to have such an amazing and engaged audience, and I see that many of you have remained for the Q&A. So thank you very much. I very much appreciate. But yeah, let's have those questions.
Will HRT manage anxiety and hot flushes? Yes. I tried SSRI, but they just gave me really bad headaches.
Yeah, no, fair enough. Yes, they do. Yes, yeah. I mean, when it's successful, it's successful, and they do help with those very clearly. Yes. Yes.
Can the various vasomotor issues affect your immune system, your general well-being, not necessarily menopause related?
The vasomotor symptoms in themselves, no. But the menopause as an overall phenomenon, maybe. Why is that? Because it has such a wide-ranging number of effects. None the least, I keep going back to this one, none the least, your sleep. We know that your sleep has an effect on your immune system directly. So if you're not sleeping well, we know that your immune system is going to be weakened, for example. So just by that very reason. So yeah, so okay, so the real answer would be, if your vasomotor symptoms are the ones that are responsible for your poor sleep, maybe there's a direct link there with your immune, with being your immune system being in some way affected. But again, the menopause in itself is a complex phenomenon, and it affects your body in general, and this, these changes could have various ramifications through various channels. As we say, it can be complex. The vasomotor symptoms in and of themselves are not directly linked to the immune system, but there may be those links that I expressed, for example, via sleep.
Okay, one last one. Does HRT just delay the menopause? So when you come off the medication, the symptoms will start again?
Yeah, so what you try to do, under the supervision of your physician, is you try and make those changes be much more, you're able to cope with them better, and then you look at how are you going to discontinue it over time. You can maintain it for a long time, it's not a problem. If you tolerate it well and it's helpful, you can maintain it for a long time. But most of the problems that the menopause has seem to be related with a very, very abrupt drop in the level of estrogens. I'll give you an example from men. So men have a drop of testosterone with age. What's the difference? Why don't they get a andropause, I'm going to call it? Yeah. Why don't they have these? Because the drop in those levels is very, very slow, as compared to the women's drop in estrogens, which is dramatic and abrupt. So sometimes what your doctor may do is they may be looking at gradually reducing those levels if that's what you want to achieve with them, and looking at how much do we need to do to control it, and do we need less, do we need less, do we need less. Sometimes people use it for a long time.
Okay, thank you. I'm conscious of time. Thank you though for asking all those interesting questions. You may ask your GP for more personal questions here as well.
Yeah.
So I think
I won't be able to address the very, very personal ones, just in principle. Yeah. We're going to, this is recorded and we're going to make it available. So if you want to sort of download it or share it with anybody, that would be great. Thank you all very much.
Thank you so much. Thank you.